Hello and welcome to New York Medical College and the Touro College and University System's 17th COVID-19 webinar. As always, I am your host, Edward Halperin. I am the Chancellor and Chief Executive Officer of New York Medical College and the Provost for Biomedical Affairs of the Touro College and University System. Well, I guess many of you have noticed we're starting our third year of these webinars, having passed our second anniversary. And when we first started doing these webinars, when we would finish up, I would say something like, well, I hope we're almost done and we won't be having to do these anymore. And then I switched to start saying, well, we'll see you again in 4 to 6 weeks as the pandemic continues. And as we start our third year of these webinars, I'm starting to think that when the time eventually comes for me to retire, somebody's going to have to put in the job description for the next Chancellor and CEO of New York Medical College that their job includes writing syllabi and helping to organize these webinars, because maybe this is going to become a permanent part of our lives. But whatever the future holds, we'll keep coming back to you with the latest information that we hope will help you navigate the ongoing pandemic. Now, our program for today is snatched from the headlines. As I worked on the syllabus for today's webinar, I thought, what are the headline issues that are probably troubling people? Thus, I asked Dean Robert Amler of the School of Health Science and Practice to talk about what kind of mask are you supposed to be wearing? Some people are giving public statements saying we all should be wearing N95 masks. We shouldn't be wearing cloth masks. And then people advertising masks with impregnated copper or silver fibers. How about some practical advice about what we know and don't know about what masks to wear? Your fan favorite, Dr. Marissa Montecalvo, Professor of Infectious Disease, is back with us to talk about how long are you supposed to isolate or quarantine? What's the difference between isolating and quarantining? And should you stay home for 5 days or 10 days? Because various new recommendations are coming out. I've asked Dr. Mel Etienne, Professor of Neurology and Vice Chancellor of New York Medical College, who's been with us for previous webinars, to talk about another issue which has been in the headlines, and that is the striking racial disparities in vaccination in the United States and their impact on morbidity and mortality rates from the Omicron variant. The Dean of the Touro College of Osteopathic Medicine, Vallejo, California, and Professor of Pediatrics, Dr. Tammy Hendricks, is back with us, and I've asked her to talk about a topic which I'm sure is troubling many parents and grandparents in our audience. First, they closed the schools, and the kids were driving me crazy. Then they opened the schools, and I sent the kids back. Then somebody in the class tested positive, and they closed the schools, and they sent the kids back home. Am I going to go nuts being a parent during this pandemic? Are my kids and I going to survive in the house together? And asked her to address that topic. And we've got someone new to join us this time on the recommendation of Dean Loray of the Touro College of Business. Mr. Shallot is with us to talk about the impact of the pandemic on the commercial real estate market and how it's affected the way we work and what kind of commercial space we rent, and what some people perceive as an upcoming very serious problem, which is with the decline of major commercial entities renting real estate in American cities, then property taxes are going to fall. And as the receipts of property taxes fall, will American cities be able to pay the salaries of policemen, firemen, emergency responders? Will they be able to run public transportation? How will that affect life in urban America? As always, if you have any questions for our panelists, please use the question and answer function on the screen. Type in your questions. We'll be monitoring them as the webinar progresses, and we'll get to as many of them as we can during the Q&A part of our program. I will be back during the interspaces between our panelist presentations to tell you how to get your continuing medical education credit and to ask you to consider making a financial contribution, charitable contribution to support these webinars, and also to tell you about some of our academic offerings related to public health and medical ethics related to the issues raised by COVID-19. The Q&A period of our program will be hosted by the president of the Touro College University System, Dr. Alan Kadish. And now let's begin with webinar number 17 with Dr. Robert Ambler.
The mask mystique. Oh my, Omicron, can you see me now? I'm Dr. Robert Ambler, and I have no conflicts to disclose. But I will remind us all that this webinar, like all the previous, has been sponsored by Touro and by the Center for Disaster Medicine here at New York Medical College. Well, there's a lot of buzz about masks, and some of that buzz is just fuzz. Lots of new experts, AKA vendors, have jumped into the game. So just to review, here are some mask basics. First of all, your mask should have at least 2 layers. It should completely cover your nose, mouth, and chin. And it must fit snugly without gaps if you want to use it to block exposure. Now, for gentlemen with beards, this is not going to work. To really get a close fit, you need to shave. And in fact, I have shaved my beard a few times during the last 2 years when I was in circumstances where I needed really tight protection to block against exposure. Now, for more serious protection, beyond the basic masks, for example, healthcare workers, we have filtering respirators. You need these because they provide a different class of protection for you. If you are caring for sick COVID patients, if you're at increased risk for severe illness, or at a job interacting with many unmasked people, if you're riding on a plane or train or bus, especially if crowded, you might want to consider a filtering respirator. Also, if you're unable to physically distance from others. And of course, if you're unvaccinated or simply not up to date on your COVID-19 vaccinations. To go for a filtering respirator, there are basically 2 types. On the left, you see the approved variety. That's the N95, which is the gold standard, approved by NIOSH, also approved by OSHA, and in fact required by OSHA for certain occupational settings to protect workers. You'll recognize the N95 because it'll say N95 on the mask. And to separate the counterfeits from the reals, look for a TC number, which has the format you see there, TC, and then some letters and digits. Typically, no, all the time, an N95 will not be designed or embellished with colors or sequins or other doodads that make it look attractive. And fit testing is required if you're going to use the N95 correctly. Now, there is another version of a filtering respirator. That would be the KN95, or in some cases, KF95. These are not officially approved, and in the US, they are poorly regulated, if regulated at all. But if you can't get an N95, you could at least go to the level of protection of a KN95, understanding that it is not the gold standard, not NIOSH approved. And again, it could be counterfeit. Now, if it's made in China, you will usually see a Chinese designation, which is GB followed by, again, some digits and the year it was manufactured. Or if it's the KF95, it should say made in Korea. Obviously, it's not hard to counterfeit that, so buyer beware. I will say, though, that the KN95s in general are more comfortable. By the way, notice one more design difference. The N95 on the left has 2 straps, one that goes over the top of your head and the other that goes behind your face below your ears. The other filtering respirators have ear loops, and that's often a giveaway that they're not really N95s. But I will say that these N95s have been studied for many years with extensive filtration studies, and not just against viruses, but also for fine particulates. Well, speaking of regulations, along with the vaccination mandates, we now have changing rules for masking. Currently in New York State, it's required to wear a mask in all indoor public places unless businesses or venues have implemented a vaccine requirement. New York City adds, and many other municipalities have added, that you must also wear a mask when you're in crowded outdoor settings, not specifically defined except crowded outdoor settings. In the United States, the federal government has just announced ordering another 400 million N95s, but how long it will take to get them and whether that will be an adequate number of masks remains to be seen. And remember, you are still in violation, at least biologically, if not regulatory-wise, if you violate these mask requirements. Sorry about that. First of all, do not wear this around your neck, on your forehead, under your nose, only on your nose, on your chin, dangling from one ear, or over your arm. And remember that these types of masks, the basic cloth or surgical masks, are still not considered PPE, personal protective equipment. Now let's move on and explore the new age of masks. It's been known for centuries, going back to ancient times, that there's an antimicrobial effect of heavy metals, such as copper or silver, many others, mercury and zinc. And now they're putting metal fibers or nanoparticles into masks. For example, copper. Copper has been used for a couple of decades in fabric incorporations, and it has been shown in laboratory studies to defeat replication of viruses and also to shorten the life of viruses that have not replicated yet, because the redox reaction that occurs on the surface of the metal releases oxygen, which is very toxic to virus particles, and also releases free radicals. Both of those are very injurious to the virus particle itself. A study in Korea of copper sulfide showed, and you can look all the way on each of these charts, look all the way on the right side, showing that a 3-layered mask with copper sulfate markedly diminishes the amount of replication of the virus, as well as the presence of virus in the air traveling through the fabric. But again, these are not clinical mask studies, they're laboratory studies. Now, silver also has great antimicrobial effects. We use it all the time on burns and wounds. Remember, silver sulfadiazine. We use silver nitrate, cautery, on umbilical stumps and other tissue. And believe it or not, some condoms now are manufactured with silver nanoparticles in an effort to reduce gonorrhea and other sexually transmitted infections. The actual studies, laboratory-wise, you see one here, 2 of them here actually presented, disappointing results. There's a variable result on the left in terms of actual diminution of virus depending on the type of study, and the the photograph on the right shows that actually in one of these studies there was no silver whatsoever in the actual mask. So the consensus right now among the public health infectious disease community is that the use of copper and possibly silver in masks sounds promising, but not quite ready yet for prime time. First of all, it's a question of validity. If the silver is not present at all, obviously the silver is not going to help. So what metal and how much metal is actually present in the actual product? There are safety concerns. Silver nanoparticles have been shown to be inhaled, and they are injurious to respiratory tissue when they're inhaled. There is also a phenomenon of silver toxicity as well as copper toxicity. I recently consulted on a teenage patient who had an elevated copper level. So we need to think about all the pharmacological implications of introducing heavy metals into our inspired air. The efficacy in the lab can look good, but we really haven't seen or looked for negative studies. And as a science supervisor for many years at CDC, I always valued the investigator who publishes a negative study, because we know the incentives are not always there to publish something that does not show a benefit of something. So we really need to look carefully at those studies. The efficacy on the face during actual exposure has not been studied in any reliable way so far. And we need to wait for that before we weigh in on whether these new age masks are appropriate. And the bottom line is, will people wear them properly? The introduction of metal fibers in a mask makes it stiffer. And a stiff mask may not conform to the sides of your face the way a mask should, just like we discussed at the beginning of this discussion. And the bottom line, of course, is, will people wear them properly? So what's coming next for this virus that's full of surprises? Well, we know there will be more contagion from Omicron and its heirs. We expect milder illnesses, and we hope that will be the case. But the threat persists, and people still die from this. So my recommendation, stay cautious, mask to block exposure, and vaccinate. Thank you.
Hello again. This is your host, Dr. Edward Halprin, and I'm back to tell you how to get your continuing medical education credit for those of you seeking CME credit from today's webinar. You have three choices. You can get out that cell phone and send a text message to 828-295-1144 and type in your message the activity code 53 SILO, all in caps, SILO, 53 SILO. And then you'll get an answer back by text message, giving you instructions as to how to take the questionnaire about your satisfaction with today's program and how to get your CME credit. Or if you don't like that option, you can go to www.eeds.com and click the sign-in button, enter the same code, 53 SILO, and you'll fill out the satisfaction questionnaire, and your CME credit will show up following the instructions that way. Or you can take out your cell phone or your iPad and scan that QR code, and it'll take you to the spot to sign up with your activity code and get your CME credit and fill out the questionnaire. May I recommend you either take a screenshot or get out your cell phone and take a photograph of the slide, or quickly write down this information so you can get your CME credit. Remember, it's going to stay live until Tuesday, February 1st at 12:30 p.m. So you have a limited amount of time to sign up for your CME credit. Remember that if you have a question for any of our panelists, use the question and answer function on your computer, type it in, and we'll monitor them and get to as many of them as possible during our webinar. And let's get back to our program.
Good afternoon. I'm Marissa Montecalvo, and I'm speaking on 5 versus 10 days for isolation and quarantine and trying to figure out what's happening with that. I have no conflicts of interest to disclose. So let's start with definitions of quarantine and isolation. Quarantine is for those who have been exposed to SARS-CoV-2, and it's to stay home and stay home after you've been in close contact with someone who's infected. Whereas isolation is the term used when you're either symptomatic and then test positive, or asymptomatic and test positive. And although day to day we do approximately the same thing when we're on isolation or quarantine, the terms are different to distinguish those at risk of infection because of contact versus those who have infection. The timeframes are different. Quarantine is for the incubation period where you could be developing infection, and that's 2 to 14 days, whereas isolation is from the moment you know you have infection out to approximately 10 days. And it's different whether you're in healthcare, the community, or in a congregate setting. So you know what happened in December. The case rate soared when Omicron hit. These are data that came from Denmark, which started to give us some information that ultimately led to these changes. So this looks at secondary transmission in households during the Delta, when the Delta variant was prevalent, versus Omicron. And you can see that among the unvaccinated, about a similar percentage of unvaccinated people in households became infected after there was a case in the household. But what was striking here is what happened among the fully vaccinated and those who were boosted. And although the boosted still did better overall, clearly infection was being acquired by those who were vaccinated and even those who were boosted, which is a worrisome scenario. Similarly, these are data from England looking at vaccine effectiveness over time and looking at it in Delta in the squares versus Omicron. And you can see the falling vaccine effectiveness against infection for the Pfizer vaccine with 2 doses over 25 weeks. The middle panel is being boosted with a Pfizer booster, and the last panel is starting with Pfizer and then having the Moderna booster. But either way, in each of these, you can see how worrisome the first panel is. Boosting gives you a benefit, but you're still not where you were during the period that Delta was present. Lastly, coming out of South Africa, the good news was that if one looked at the rate of hospitalization, it was lower. And this paper from JAMA looks at the 4 waves of infection in South Africa, and you see a statistically significant lower percentage of patients admitted with severe respiratory syndrome, much less than in previous waves, and admissions were predominantly among the unvaccinated. So all of this information comes together in December, and in particularly the soaring case rate against the issue that the unvaccinated and fully vaccinated are acquiring infection at the same rate, led CDC to seriously consider what the negative societal impact was going to be of this vast number of people either sick or requiring isolation or quarantine. What would staffing shortages look like, supply chain shortages, and the general effect of this on the population at large and the needs for testing. So the first thing that happened was on December 23rd, they said for healthcare specifically, we could consider shortening isolation to 5 days from 10 days as a contingency strategy to mitigate shortages. However, that was only providing that the healthcare worker was well enough to return to work and felt able to return to work, and the healthcare worker still had to mask 24/7 between days 5 and day 10 and physically distance as much as possible. This was a contingency strategy. So along with this, they had looked very carefully at the period of infectiousness, and that is the top graph that you see. Day 0 is where one develops symptoms or tests positive. And as you know, you are infectious at least a couple of days before that. The inner line is showing you the period of infectivity. The outer line is the period of PCR positivity, which correlates to viral load. So you can see that this line slopes down quickly between day 2 and day 3, and then starts to come down. Immediately below here is a graph looking at testing. And again, PCR can remain positive after you are no longer infectious. So you see that here. And early on, antigen would be your very good test to detect infectivity. So with that in mind, they also shorten guidance for the community at large, saying if you start at day 0, which is where you either develop symptoms or test positive, clearly you were infectious beforehand, use your stringent measures for the 5 days where you're most infectious, and then wear a mask for day 6 through day 10. And this is that guidance in greater detail. Stay home for the 5 days, wear a mask even at home, but after the 5 days, and only if you meet these criteria, do you come off isolation, and then you continue to wear a mask, avoid travel, and avoid being around anyone who's at risk of at high risk of SARS-CoV-2. So CDC makes recommendations, but the state has to adopt these as to how they will be implemented. And this is a summary of where we're at right now as per the New York State Department of Health. So both for healthcare and for the community at large, but not congregate settings. Congregate settings being daycare, shelters, prisons. For the community at large, it's 5 days of isolation. There also have been changes to requirements for quarantine. So if you are exposed and you're either unvaccinated or not up to date with your vaccine, meaning you're eligible for a booster, but you have not yet received it, then this is new. You would now be required to quarantine for 5 days. If you develop symptoms, then you have to isolate. If you are up to date, then no quarantine is needed. And if you've had infection within 90 days in the community, no quarantine is needed. And lastly, regarding testing after exposure, it is still strongly advised at least 5 days after exposure, just that because a PCR can remain positive if you've been infected recently, then it is not advised. And just a few days ago, the State Department of Health issued guidance that in healthcare and in healthcare within Article 28 facilities, all healthcare workers must be up to date, that is, having received their booster within 30 days of eligibility. So in summary, we are now at 5 days of isolation instead of 10, capturing that period of greatest infectiousness, but that is providing the person is asymptomatic or clearly improving and can wear a mask and practice these safety measures between days 5 and day 10. And this is not for people who are immunosuppressed or had severe disease. Number 2, in the community and in healthcare, 5 days of quarantine is now required for unvaccinated persons or persons who are not up to date with their vaccination, and testing is still strongly advised. So where are we at? I think that basically these changes were put into place to place greater responsibility upon the public at large, that to focus isolation and restriction during the period of highest risk, but with the public understanding that they would still be responsible for other measures. And I think that this is with keeping in mind that there will be a need for intermittent isolation and quarantine as the months go on and as new variants evolve. Thank you very much. I look forward to your questions, and here are my references. Thank you.
Hello again, this is your host, Dr. Edward Halprin, to remind you to consider giving back to New York Medical College to support these webinars. These webinars are provided at no charge to you. Indeed, for those of you getting CME credit, there is no charge for the CME credit. But free webinars and free CME credit are, of course, not free. The college has considerable expenses putting on these webinars and generating the CME credit. We hope that some of you will choose to financially support these webinars and our research on COVID-19 at New York Medical College. Our programs require time, effort, and funds, and by making a tax-deductible gift, your donation will help offset our costs. Great things are happening at New York Medical College. We hope you'll all choose to be a part of it, to make a gift back to the college to support this webinar. You can phone 914-594-2720, and one of our development officers will be happy to take your credit card information over the phone. Or you can go online, www.nymc.edu/give, and make your donation online. And if you like to use the high technology of a pen and a checkbook, that works for us too. Checks may be made out to New York Medical College. Please write in the memo line of your check supporting COVID-19 webinar or supporting COVID-19 research. Put it in an envelope with a stamp and send it to New York Medical College, Office of Development, 40 Sunshine Cottage Road, Valhalla, New York, 10595. And we thank you for thinking of us during these challenging times. We hope everyone's staying safe and healthy. Remember, if you have a question for any of our panelists, go to the Q&A function on your computer screen and type it in there, and we'll monitor them and get to as many of them as we possibly can during the Q&A session of today's program. And let's get back to the presentations by our panelists.
Hello, my name is Mel Etienne, Vice Chancellor for Diversity and Inclusion here at NYMC. I am also the head of the Health Equity Task Force for COVID-19 vaccine distribution in the Lower Hudson Valley. Today, I was asked to answer the question, what is the explanation of continuing racial disparities in COVID-19 vaccination rates, and what should we do about it? I have no conflicts of interest. In the United States, the first vaccine for COVID-19 became available in December 2020, and we now have 3 vaccines available. As you can see on this graph, 76% of people in the US have received at least 1 dose of the vaccine, and 64% have received 2 doses or are fully vaccinated. Additionally, 25% of people have received the booster. Our vaccination rates are better in New York, with 87% of people having received 1 dose and nearly 74% of people fully vaccinated. From the time the COVID-19 vaccines first became available, there have been racial disparities in vaccination rates. It is important to keep in mind that there are many social, geographic, political, economic, and environmental factors that create challenges to vaccination access and acceptance, and that often affect racial and ethnic minority groups. Early in the pandemic, much of this disparity was attributed to inequities in access to the vaccine. This includes challenges with scheduling vaccines, getting to the vaccination site, and limited availability of the vaccine in certain communities. As the vaccine became more widely available, there was an increasing role for vaccine hesitancy. However, the previously mentioned factors remain contributors as well, with their impact varying by community. As you can see in this graph, the most recent data shows that 81% of Asians, 60% of whites and Hispanics, and 54% of Black people in the United States are vaccinated. Vaccine hesitancy is the delay in acceptance or refusal of vaccine despite availability of vaccine services. This is complex and context specific and can vary by community and by individuals. Common reasons for vaccine hesitancy include skepticism, complacency, convenience, and confidence, which can all interplay to contribute to an individual or a community being vaccine hesitant. We now have good treatments for COVID-19, and we have seen a drop in the mortality rate overall. So some people may feel like they're unlikely to get it, and if they do get it, they're unlikely to die from it. It is important to keep in mind that many of the people who have vaccine hesitancy may still get the vaccine, particularly with appropriate engagement and messaging. Hesitancy does not mean vaccine refusal, so do not miss an opportunity to educate someone and convince them to get the vaccine. As you can see from these graphs, the COVID-19 rates were fairly low throughout the months of November. This could lead to a sense of complacency for those who are unvaccinated. But as you can see, in December and into January, as the Omicron variant made its way to our communities, there was a rather sharp divide between the vaccinated and the unvaccinated. The unvaccinated account for 6 times the number of cases, 8 times the number of weekly hospitalizations, and 8 times the number of weekly deaths from COVID-19. The Omicron variant, once again, led to more pronounced disparities with regards to who is getting infected and who is dying from COVID-19. This graph of data from New York City demonstrates what has been true for each wave of the pandemic, which is that older people and African Americans are more likely to have serious disease from COVID-19 infection requiring hospitalization. Next, we will consider what we can do about these disparities. I will illustrate by going over what we have done in the Lower Hudson Valley to get our vaccination rates to be among the highest in the country. For starters, it is important to have printed materials and advertisements representative of the community. In addition to having printed material in English, our Health Equity Task Force had materials printed in languages of the people in the community. This includes Spanish, French, and Haitian Creole. Our Health Equity Task Force has had a major focus on community engagement. Our mission is to ensure an equitable distribution and administration of the vaccine throughout the region. What we have done is identify the communities with low vaccination rates by looking at zip code data, and we've devised strategies to increase the vaccination rates in those communities. This includes utilizing the mobile coach unit to go into communities and sign them up for the vaccine, partnering with trusted community organizations, and having conversations through Zoom, WebEx, and other virtual platforms. These community conversations have been helpful in dispelling myths about the vaccines and providing our community members with accurate information so they can make an informed decision regarding their health. We have also used these conversations to gain better understanding of who is hesitant and why they are hesitant. With this understanding, we have been better positioned to provide clear and consistent messaging to those community members. Many reasons people have provided with regards to why they are not being vaccinated have included concerns about not trusting the government regarding prior unethical experiments done on marginalized segments of the population, such as the National Public Health Service syphilis study on the men of Tuskegee, Alabama. Others say they just want to wait and see how the vaccine impacts others. We have also encouraged our partners to offer flexible hours for vaccination so that people do not have to miss time from work to get the vaccine. It is important for people educating the community to have answers to commonly asked questions. Be ready to provide information on how to get the vaccine. Where can I go? How do I sign up? Right now, many people don't even need to sign up. You can actually just show up to a site and often get vaccinated. I recall recently, I was coming out of a museum with my children, and on the way out, they actually asked, do you want to get a vaccine? And since I was due for my booster, I just got the vaccine. Easy as that. When people raise concerns, it is important to validate their concerns and helping to dispel these myths. Providing clear, respectful, and honest answers to community members can go a long way. It is important to make it clear to those members that the vaccines were made using processes that have been developed and tested over many years. Finally, we need to make sure that our institutions are trustworthy, transparent, and engaging all communities. If you don't have partnerships with local community organizations like the NAACP, Black and Hispanic coalitions, YMCA, YWCA, United Way, these are very important community partners. And lastly, I'll say early in the pandemic, we stressed that wearing masks were to protect not just ourselves, but our friends and loved ones, we can use the exact same strategy for this vaccine. Get the vaccine to protect those folks who are not able to get the vaccine, like children under the age of 5, or others who are not able to mount an appropriate immune response. Remember, it takes a village. Thank you.
Hello, this is your host again, Dr. Edward Halperin. We have gotten some inquiries from attendees of these webinars in which the people want to know if I am really interested in some of the public health management issues that are being raised by COVID-19, or if I'm really interested in some of the medical ethics issues that have been raised by COVID-19 and that you've been addressing in these webinars. How would I sign up for an occasional course in public health or a course in medical ethics done online? How might I get a certificate in these disciplines? Or maybe I or a family member or a child or a grandchild might want to think about getting a master's degree in public health or a master's degree in biomedical ethics. To respond to such queries, we are offering you these links. If you take a screenshot or write down these links, they will take you to an entry to our web pages for our Masters of Public Health program and our Master's program in Biomedical Ethics. And you can take a look at our course offerings. Perhaps you just want to sign up for one course, or maybe you're interested in this as a career pathway for you or for someone you know. So take a moment to take a screenshot or write these links down. We hope they will be of interest to some of you. And now let's get back to our program.
Hello, my name is Dr. Tammy Hendricks, and I'm the Dean of Touro University, California, College of Osteopathic Medicine. I'm talking to you today to help answer the question, how is a parent to cope with raising school-aged children and navigating the ever-changing school systems in the pandemic? I can say, as a mom of school-aged children, I understand this question very well and all the stress that comes along with it. I have no disclosures for this presentation. First, let's take a look at the current state of pediatric COVID-19 cases. I want to draw your attention to the yellow lines on this chart. They represent the pediatric age groups. We can see in the beginning of the pandemic, children contracted COVID-19 far less frequently than adults. But with new strains and pediatric vaccines coming out later than those for adults, we've seen a shift, and there's been a dramatic increase in the number of pediatric cases. As we look at some specifics, this data is as of January 20th, 2022. There have been a total of 10.6 million cases of pediatric COVID-19 in our country. This represents about 18.4% of all COVID-19 cases in the US. Just within the week of January 13th to January 20th, we've had 1.15 million pediatric COVID-19 cases. Represents 25% of all COVID-19 cases in that same time period. Overall, we've seen a 25% increase in pediatric COVID-19 cases just in the 2 weeks, January 6th to January 20th. So that statistically, the pediatric patients tend to do a little bit better. About 0.1 to 1.5% of cases are hospitalized, and that's cumulatively. Sounds like a very small number, but if you look at the total number of cases that we're seeing, over 1 million cases a week, it's not an insignificant number of kids who are being hospitalized for COVID-19. Similarly, when we're looking at the morbidity, we have 0 to 0.02% of cases result in death in the pediatric population. Once again, if we're looking at over 1 million cases a week, that is not an insignificant number. What children have been experiencing have been these frequent interruptions to school, from shifting to purely virtual, hybrid, fully in person, and back again. With the Omicron surge, we've had school closures across the country due to widespread infection rates, leading to teacher and staff shortages. There are varied and changing policies around isolation, quarantine, when to return. All of those have led to increased absences. We can see a number of different articles have highlighted and studied the added stress that parents are under during the time of COVID-19. The confusing, inconsistent messages from the school make it difficult to plan ahead. School closures due to high number of teacher shortages, along with children needing to stay home when they're sick, make it difficult for working parents to continue to work as usual. The lack of guidance from schools adds to parent stress levels, as does concern, stress of not sending kids to school. We saw back in 2020 how detrimental it is for children to miss out on the socialization, physical activity, emotional development, and academic achievement that school provides. And finally, parents are still concerned about their kids contracting COVID-19, with the possibilities of multisystem inflammatory syndrome, MIS-C, or long COVID, resulting in kids who've had mild or asymptomatic infections. We've even seen that kids who've had COVID develop diabetes within 30 days of their COVID infection, 2.5 times more often than kids who don't contract COVID. Here's parent stress levels from May to September of 2020. Further studies show that parents continue to have similar stressors: lack of money, lack of food, lack of time due to increased work, change in daily routines and structure, worry and anxiety around COVID-19, child's worry and anxiety around COVID, child's online schooling demands, and child's desire to be with their friends. We've seen that some schools are able to keep kids safe during this pandemic. This study highlighted a school that only had 7 positive cases over 13 weeks. They were successful because they implemented the risk mitigation factors of mask use, small groups, physical distancing, and clear quarantining of individuals who'd been exposed. The problem is that not all schools are implementing these strategies. In fact, only 13 states require masks indoors, 7 states ban mask mandates. All the rest leave it up to individual counties, school districts, and schools themselves. So how do we keep kids safe during all of this uncertainty? First and foremost, vaccinate them. Right now, vaccines are available for everyone above the age of 5 years. Boosters are available for everyone above the age of 12 years. The personal relief that I have felt since my school-age kids were able to get vaccinated back in November has been immeasurable. Upgrade their masks. Cloth masks don't offer enough protection. It's time to switch your kids over to KN95, KF94, or N95 masks that better protect us. My kids have even said that they prefer the KN95 masks that they're using now. The days of sending our kids to school when they have a sniffle or a cold are over. Now, when our kids are sick, we need to keep them home to help protect everybody. In a similar vein, when they're sick, we need to get them tested for COVID so that they can isolate if necessary and we can notify the school accordingly. Sticking to the basics, reinforcing that good hand hygiene, washing hands before eating, after playing on the playground, after using the restroom, etc. And finally, establishing new routines is so important for their well-being. How do we help parents cope during all of this? Encourage the use of extended family resources and community resources. It takes a village to raise a child, and now's the time for us to reach out and connect with our village. Keep in touch with family and friends. Keep your child on a daily routine. It's going to help decrease stress and uncertainty for you as well. Do family activities together. Manage anxiety, both your own and your child's. Control COVID-19 information seeking, that doom scrolling that some of us have a tendency to do. It's time for us to stop that. Focus on big priorities, let small tasks go, and take time for yourself. Thank you very much.
Hello again. This is your host, Dr. Edward Halprin, and I'm back to tell you how to get your continuing medical education credit for those of you seeking CME credit from today's webinar. You have three choices. You can get out that cell phone and send a text message to 828-295-1144 and type in your message the activity code 53 SILO, all in caps, SILO, 53 SILO. And then you'll get an answer back by text message, giving you instructions as to how to take the questionnaire about your satisfaction with today's program and how to get your CME credit. Or if you don't like that option, you can go to www.eeds.com and click the sign-in button, enter the same code, 53 SILO, and you'll fill out the satisfaction questionnaire and your CME credit will show up following the instructions that way. Or you can take out your cell phone or your iPad and scan that QR code, and it'll take you to the spot to sign up with your activity code and get your CME credit and fill out the questionnaire. May I recommend you either take a screenshot or get out your cell phone and take a photograph of the slide, or quickly write down this information so you can get your CME credit. Remember, it's going to stay live until Tuesday, February 1st at 12:30 p.m. So you have a limited amount of time to sign up for your CME credit. Remember that if you have a question for any of our panelists, use the question and answer function on your computer, type it in, and we'll monitor them and get to as many of them as possible during our webinar. The pandemic has raised profound issues about informed consent, medical experimentation, and disparities in healthcare and the way people in positions of power treat those not in power. We thought, therefore, that many of you in the audience would be interested to know that New York Medical College and the Touro College and University System will sponsor an international online symposium on April 28th, 2022, to correspond with Yom HaShoah, Holocaust Memorial and Remembrance Day. And our symposium will concern itself with the 75th anniversary of the Nuremberg doctors' trial, which began in 1946 after World War II had ended, and the verdicts were delivered in 1947, 75 years ago. A group of German doctors and hospital administrators were placed on trial for crimes against humanity, the unconsented medical experimentation, the eugenics program, and from this came the Nuremberg Code for Medical Ethics. If you would like to register for this free program, here is the link to do so. You might want to take a screenshot or take out your cell phone and take a picture of this slide. Registration and attendance and CME credit for this program on April 28th are free, as they are for our COVID-19 webinars. And now let's return to our program.
Good afternoon, everyone. My name is Dan Shallett, and I'm a commercial real estate professional with over 20 years experience in the New York metro area. I have no conflict of interest to disclose. Today, I'm going to give you my opinion on two important topics and then take some questions. First, what's the outlook of the commercial real estate market in the current and post-pandemic world? I'll answer with a focus related to retail and restaurants, which is my background. I feel all commercial real estate owners, either landlords or lessors, meaning renters, should focus on four key areas when buying or leasing in the new normal: adaptability, convenience, safety, and technology. Being flexible and being able to adapt to changing conditions like a pandemic will be imperative for large or small companies. What we've seen over the last 2 years is that change can be dramatic and happen very quickly. Companies that can move on a dime will be the ones that survive and thrive. Two is convenience. This has always been and will continue to be a driving factor for Americans. Whether in big cities or rural America, locations that are convenient will drive success for any restaurant or retail brand. Having a drive-through, being highly visible, having great access will lead any brand to market dominance. This means landlords will want to own and hold those types of real estate assets. The third is safety. Safety is a key post-pandemic world requirement. I'm not just talking about the safety of customers who walk into a building or a retail store, but the safety of the employee. If an employee believes they're being taken care of, it will lead to higher employee retention and an overall better staff, which ultimately will lead to higher profits, whether you're the retailer that's leasing space or the owner of the building. Prior to the pandemic, many companies took this for granted, but looking forward, employees are going to ask for more, and employers are going to need to take greater care and give more. Last but not least is technology. It's already proven itself time and time again to be one of the biggest success factors for all businesses, and it's no different in the commercial real estate industry. Whether being able to use your phone to review real estate opportunities, take a video guided tour of real estate, place an order in advance of getting to the location you're going to, or even using a tablet inside a restaurant instead of having waitstaff. Investments in technology help any company stay ahead of competition and drive profitability. I listed this one last because while technology is highly important, it can also be very expensive. And it's imperative that you balance investment with return on your investment. Even large companies can overinvest in technology, and that fine balance between spending too much and increasing profits could be its own masterclass altogether. The second topic is how will large cities adapt to the potential loss of real estate tax revenue? This is a complicated and very tricky question to answer. There will not be one universal response. I'm sure we'll see a variety of responses. Every city will handle the transition a little bit differently. First thing to remember is that the taxes will be paid. There may be delays or deferred payments of taxes, but ultimately the owner pays the taxes or risks losing the real estate. Now, there is a small chance that government regulations may waive or postpone taxes for small landowners or business owners. This could force some cities to raise property tax to help balance the coffers. Other cities may decide not to raise taxes but reduce services like street cleaning or repairs and maintenance. In the end, I feel taxes will be paid, and most likely we'll see increases in property taxes over the next 2 to 5 years. I think everyone knows the famous quote, "There are only two certainties in life, death and taxes." With that sad thought, I wanted to end on a more positive outlook. While everyone listening should know change is inevitable, if you live in New York, you know change is the spark of growth. And while sometimes it's uncomfortable, in the past 30 years, the real estate industry has continued to thrive, being a city of change and good fortune. Thank you very much and have a great day.
Hello again. This is your host, Dr. Edward Halprin, with a word about how you can support this program and others like it that you have been watching. We hope you understand that while we are happy to provide free CME credit and provide these programs at no charge, providing these programs has real costs for the college in our time to prepare these lectures, to prepare the slides, and the technical work to put together programs like this. We hope you'll consider making a tax-deductible gift to the college to offset the costs of doing these programs or support our research in virology, including on COVID-19. Great things are happening at New York Medical College, and we hope you'll want to be a part of it. We ask that you consider making a gift to this program to the college by either phoning 914-594-2720, and a real person will be happy to answer the phone, take down your credit card information, and take down where you'd like your gift directed, either to these webinars or to our virology research or to whatever you desire. Or you can go online to www.nymc.edu/give and make your donation online with a credit card. And finally, if you'd like to get out that checkbook and take a pen and write a check to New York Medical College and put on the memo line where you'd like the money to be directed to, we will be delighted to receive it at New York Medical College, Office of Development, 40 Sunshine Cottage Road, Valhalla, New York, 10595. We do hope you'll consider supporting this program and our COVID-19 research. We thank you for thinking about us during these challenging times. We hope you're all staying safe and healthy. And now it's time to turn to the question and answer portion of our program, moderated by the president of the Touro College and University System and New York Medical College, Dr. Alan Kadish. Dr. Kadish, the podium is yours.
Thank you very much, Dr. Halpern. I'd like to welcome everyone. We've had a tremendous number of questions today, I think demonstrating the interest in the topic and the great job the speakers did. So we'll try to get through in the next 27 or so minutes as many of those questions as we can. First question is for Dr. Hendricks, having to do with boosters in children. If a child had a reaction to one of the first 2 doses of the vaccine, would you recommend a 3rd dose?
Thank you very much for that question. I need to know more information. I would say it's probably best to discuss the exact reaction that the child had with the child's pediatrician, so you can see what the reaction was, what it was thought to be. We have certainly seen some of the children who did get myocarditis right after receiving the 2nd dose, did go on to get boosters without any further reaction. But I would have to say that it needs to be an individual case-by-case basis, depending on the severity of the reaction and what caused it. Thank you very much for the question.
Sure. Speaking of myocarditis, there was another question about myocarditis. How common is it? How severe is it? And should it affect the decision to vaccinate?
Thank you so much. I think anytime you are considering any medical intervention, such as vaccination, you do need to weigh the risks and benefits. We did see a slight increase in the incidence of myocarditis and pericarditis in young adult males specifically following the vaccination. There was a very slight increase, so the risk is low. And what we've seen of almost all of those cases is the myocarditis was very, very mild, most of the time resolving without any medical treatment or needing very little medical treatment. We know that COVID itself can also cause myocarditis. And generally, when COVID causes myocarditis, it tends to be much more severe and have a greater impact on the child's health. Since we've been doing boosters in children, we haven't seen any additional cases of myocarditis due to the booster vaccine. Thank you.
Thank you. That's encouraging. Perhaps we'll get back to you a bit later, but I now have a couple of questions for Dr. Etienne. The first is, what do you think about economic incentives to get people vaccinated? A number of people, including Touro College, have done that. Mel, are you with us? There we go.
Yes, sorry about that. Yes, thank you for that question. While the financial incentives, I know many people have appreciated them and have benefited from them. My personal thought is that we should really focus on educating and engaging people in the community so that they can get a better understanding of their health, the benefits of the vaccine, and getting vaccinated. With that said, I've had many patients who have told me that they were waiting for a financial incentive in order to get the vaccine. And for those people, the ones that I've spoken to, they've known that they said, yeah, I know the vaccine will probably benefit me, but I'd rather wait for some form of monetary gain. So I personally believe in education and engagement as the best route. But the financial incentives, clearly, they also work to some degree.
They work. Fair answer. Second question, Dr. Etienne, is what about the racial disparity in the availability of masks and test kits? Have you seen that as a major issue? And what, if it is, what can we do to try to address it?
Right. So access to test kits has been a significant problem. The test kits, they're costly. Not everyone can afford to purchase them. As we saw recently, the US government has offered to give out 4 test kits per household. This can pose a significant problem for certain underserved communities, where there are multiple generations in the actual household, and many of these households will have far more than just 4 people living in them. And we know once one person in that household is infected, it's likely that, especially with Omicron variant, many will be infected. So the 4 test kits, while it's a nice gesture, it's actually an inequity, a disparity in itself. And we all know from throughout the pandemic, the numbers have been dramatically underreported. Now with those home test kits available, it can help us to do better reporting, but in reality, 4 test kits, in my opinion, is not enough. And there should be some other way of deciding how many test kits certain household would get. Thank you for that question.
Sure. I think it's been a national problem that we haven't had enough testing available. And I think government on all levels is trying to address those. And so hopefully as availability increases, the government will be able to make more tests available to others. I do believe they're actually free if you're able to find them. So it's not just the test kits that the government has sent out, but that they're now free and it's availability that's the challenge. But we appreciate the fact that economic disparities make it harder to deal with testing and with masking. So thank you for those answers.
Absolutely.
Now I'm going to have a couple of questions for Dr. Amler. Dr. Amler, welcome.
Thank you.
So what about the price of these metal impregnated masks you talked about? Are they significantly more expensive than the regular masks? And is that a barrier to their uptake?
Well, I think thank you for the question, but I don't have specific pricing information. And as I said in the beginning, I have no conflict to disclose as part of the presentation. So I won't be advocating one product over another. The fact is they're being promoted very aggressively. That concerns me, especially the decorations, the sequins, the other doodads that are on these devices, which are really intended for protection. It's significant that the gold standard, the N95, does not have any embellishments and is free of the metallic add-ons that may or may not be beneficial. And I'm not saying that they're harmful, but we have to look at the potential for ill effects from the metal exposure. So I think rather than shop for them and try to get the best price, if the latter part of that question is, are they worth the money? I would say, since they really have not been recommended at this stage, no, they're really not worth the money, not right now. And thank you for the question.
Sure, thank you, Dr. Amler. So a couple of other mask-related questions. What about surgical masks? For a while, we were advocating the use of surgical masks, and I'm going to merge a few questions into one. So if you can't be properly fitted for an N95 because you don't have access to a fitting station, are you better off with a regular fitting surgical mask or an N95 that hasn't been fit properly? Is it really that clear which of those is better?
That's a great question. Unfortunately, it's a little bit saying, is it colder in the winter or is it colder in the mountains? You know, it depends on many factors. In this case, you know, an unfitted N95 is not endorsed or recommended, but you know that you can do some of that fitting yourself by clamping it tightly around the sides of your face. And you could even have a friend or family member do a crude test of the fit by spraying an air spray or an air freshener around you in the general area, staying away from your eyes, of course, and tell them if you can smell it. If you can smell it, then you don't have a very good fit, do you? And of course, if you have a full beard like mine, no matter how tightly you clamp, it's not going to be a perfect fit. That said, the level of filtration going through the material in the mask is still going to be a higher level of filtration than a surgical mask, which is basically a paper cloth type material on several layers. So a surgical mask is good, an N95 unfitted, if you do the best you can to tighten it around your face, I would say is still better, even though that's not endorsed by the government agencies. And a properly fitted N95 mask is the gold standard. Remember, all of those choices are far, far better than no mask at all. And thanks for the question.
Sure. One follow-up mask question is, what about the duckbill N95 mask? It looks a little funny, but it tends to be easier to fit, right?
Yes, you can be an ugly duckling. That's okay. If it's an N95, if it's properly fitted, this is just a different design of an N95. And, you know, it is an acceptable way to protect yourself with that higher filtration. Remember, we call them filtration respirators as opposed to masks, because they are part of your personal protection. So duckbills, okay. Thanks for the question.
Sure. Quick question for Dan Shallot. What do you think the long and short-term impact on employment in the real estate sector will be? Have you seen an impact, and do you see that going forward?
Thank you for the question, Dr. Kadish. Yeah, absolutely. This is an interesting topic for me. We have seen employment rates go down in the sector in all categories, except for commercial homes or residential homes. Residential home sales have gone up, but in the commercial side, multiple people have sort of pulled out of the business. I do think there will be a rebound. It's just a timing of when it comes back. But the long-term outlook means that there will be less people with less experience in the future. So that will create a sort of a void, probably in the 3 to 5 year time frame, where there will be a void of people with that experience because they're not in the markets today. So that will have an effect on sort of all aspects of real estate. When you don't have enough people in any one given category, there's going to be an impact.
Thank you.
Thank you for the question.
Sure. Dr. Montecalvo, we have several questions for you. And I'll start with a question of whether you have any evidence that COVID-19 vaccines affect menstrual cycle or fertility in women and in men.
Thanks. Thank you. I don't think there's any evidence that they affect either menstrual cycles or fertility. I do not know of any information along those lines. Thank you.
Sure. The next question. How long should you wait before getting your first booster? And I call it first booster because some of the subsequent questions will talk about multiple boosters. But how long after your second vaccine dose should you wait for a booster, or after spontaneous COVID-19 infection?
Yeah, thanks very much. That's an important question. So if you have not had infection, it is 5 months after receipt of dose 2 of a messenger RNA vaccine, or 2 months after receipt of the Janssen vector vaccine. That's the interval for boosting. that interval was recently changed from 6 months after messenger RNA to 5 months, but for both Pfizer and Moderna. Now, what happens when you've recently had SARS-CoV-2 infection, as many hundreds of people have just had? So throughout the pandemic, there's been evidence that, it is likely that for 3 months after natural infection, you're very likely protected, unless, and in fact, it's advised not to test during those 3 months unless you develop symptoms, as long as you're asymptomatic. So no one knows the duration of immunity that will be conferred by Omicron natural infection yet, but along known for previous variants, I think that's the general recommendation that we would follow. Can you receive a vaccine earlier? Absolutely. Let's say you had natural infection because you were overdue for your booster. Once you're off isolation, you're eligible to receive a vaccine. But if you choose to wait, I would say 3 months is the interval.
Good. So following up on boosters first for a second, what about a fourth shot? Do you ever recommend getting a fourth shot? Are there any specific groups where you might recommend it? Or do you think we need more data before making those recommendations?
So there is a specific group that is currently eligible for a fourth shot, and that is severely immunosuppressed persons. So around August 20th, for those persons who are severely immunosuppressed, such as a kidney transplant recipient, someone receiving chemotherapy for cancer, someone on high dose immune suppression, those people were eligible for a third dose as part of their primary series, because data had come out that they had not mounted a sufficient immune response after 2 doses of vaccine. If you received a third dose when that first happened, which would be back in August, you then by now could be eligible for your booster, which would be 5 months after that third dose. The severely immunosuppressed individual is eligible for a third dose 28 days after dose 2. It's just that the recommendation didn't come out until August. So many of the people who received it were many months out, and it was hard to tell what was truly a third dose versus a booster. However, that group is now up to their 4th dose. There's no one else that is currently eligible, and I would not advocate getting a 4th dose without data coming out.
Thank you. What about natural infection? There's been some increasing data to suggest that people who have had natural infection have significant resistance to reinfection with COVID-19. You mentioned that previously about a few months. Do you think that would you suggest that someone who's had 2 doses of vaccine and an episode of COVID-19 still get a booster? Or do you think that that may not be necessary based on currently available data?
No, I think if we just back up a minute, if you look at who got infected with Omicron, right? So those who were boosted, it was still less likely to get infected than the vaccinated but non-boosted person, right? So there was a benefit to keeping your immunity high,
right,
of reducing infection. And I agree with you 100%. There's more and more data coming out about how much immunity you get from natural infection, and we'll have to see what that shows. But I certainly don't think that that means that you might not need a booster at this point. I just wouldn't do it immediately. That's all.
Thank you. That's very helpful. Dr. Hendricks, I'm going to come back to you for a couple of questions, if that's okay.
Absolutely.
Great. So this is someone obviously with children in daycare who's asking, do we really need to test every time a child gets the sniffles? Because kind of in daycare, they seem to have it every day. So how often would you test a child in daycare for COVID-19. And, my grandchildren are in daycare, have sniffles every single day. So how often would you test in that circumstance?
That is such an excellent question and really speaks to the reality of what a lot of our parents and grandparents are facing right now. Definitely when my kids were in daycare, they had that chronic daycare runny nose. It was just happening all the time. Unfortunately, COVID, especially in kids, tends to be a great mimicker, meaning it can show up as a tummy ache or a gastroenteritis, throwing up and diarrhea, or it can show up as symptoms similar to allergies or a cold. One of the things that I've been doing so much more frequently in my clinic recently is writing letters for those poor kids in daycare so they can return to daycare. In terms of how often to test them, I think if they do have symptoms that could be consistent with COVID, it is important to test them because that's how we help to decrease the spread. How often to test them? I would say if they're dealing with the same runny nose and they've already been tested with those same symptoms, then let that resolve and wait until the next thing starts. Thank you.
Continue with children in daycare. So if a child does have a documented infection, how long before we can send them back to daycare safely for them and for the people around them?
Yeah, absolutely. Thank you. Just like Dr. Montecalvo was highlighting the newest recommendations of at least isolating for a minimum of 5 days. Ideally, doing a rapid antigen test if they are going to return after those 5 days to get an idea of how infectious they might still be would be ideal to get that negative test before sending them back after 5 days. We know that kids struggle more than adults do to keep their masks on and tend to touch their faces and touch other things a lot more. So we want to do our best to make sure that they're really not infectious when they do return. So if we don't get a negative test or you can't test, I would say to keep them out for a full 10 days.
Thank you.
Thank you for the.
Sure. I think we'll head back to Dr. Amler for a couple of minutes now. Dr. Amler, you're still with us? There you go.
Yes, I am.
Welcome back.
Thank you.
So there's a follow-up question about vaccination and transmission of disease, which I think may have been covered by one of the speakers a bit. But tell us a little bit about your view about whether vaccination impacts the spread of disease at all.
Yeah, looking back over the many, many different viral vaccines that have been developed in the last 4 decades, by and large, the breakthrough infections that occur, such as with measles or with varicella, chickenpox, it's very clear that those breakthrough infections are not very transmissible. They're not very contagious. And yet with this virus, which is always full of surprises, I think that we have all seen plenty of the breakthrough infections causing infection in other people. Now, how much of that is detailed contact tracing? How much of that is just because suddenly the virus seems to be everywhere? And if you didn't catch it from person A, you had persons B, C, D, E, and F to catch it from. It's not 100% clear. And I would welcome Dr. Montecalvo's addition to this response. But from my point of view, vaccinated people are still less likely to transmit to fewer people, but both less likely to transmit, but also likely to transmit to fewer people in fewer circumstances, i.e. it would take less of a greater distance, a greater inoculum of virus, a heavier cough or sneeze, and so forth. This is not worked out by any means. But again, I would defer to Dr. Montecalvo on any more recent information on the transmissibility in vaccinated people. Thanks for the question.
Sure. Dr. Montecalvo, you've been invited to comment.
Hi. So thank you. Yeah, tough question. I think, I would look at the Danish study that I presented. So I think that there were data on secondary household transmission, and it was less it was less to the boosted individual. You're asking, I'm sorry, actually, that's not pertinent because you're really asking, is the boosted less likely to be a transmitter?
Right.
And you know, I don't think we know that at this point. When we first had breakthrough infections, the data that came out was that the transmission looked about the same. If you looked at the breakthrough in healthcare workers, they were infectious before symptoms, and it was about the same. So I'm not sure that that it's going to change that much. You know, but these vaccines, what we have to always remember is that these vaccines are superb at reducing hospitalization, at mitigating the severity of illness. And that's very, very important. But do they stop transmission? That's harder. And I think we'll have to see what Omicron looks like.
So a follow-up question to that for both of you, really. So if that's true, then why are the isolation recommendations or quarantine recommendations different for vaccinated and unvaccinated people if we now have increasing data that even vaccinated people may transmit, particularly Omicron, at a similar rate to unvaccinated people?
Well, so if we start with isolation, okay, so take the person who's infected. So we're saying that the person who's infected, whether they be vaccinated, whether they be up to date and boosted, whether they be fully vaccinated and unboosted, or whether they be unvaccinated, right? Those three categories, they can still transmit.
Right.
Right. So isolation is the same for those three categories. So that's actually consistent. The place where things differ is with quarantine, which is in the circumstance of exposure. And there you're subject to quarantine if you are not boosted or not up to date. And the reason for that is because you are more likely to acquire infection if you are non-boosted or not up to date. And that actually circles back to that Danish study that if you look at that, right, it was the non-boosted who and the unvaccinated who had the highest rates of acquiring infection.
Thank you.
To summarize then, it's not so much the infective dose, but the status of the person who could be the recipient of the next exposure.
Exactly.
And what their immune status is. If they're completely unvaccinated, they're completely vulnerable to what comes next. If they've had the infection before, they've got some immunity. If they've been vaccinated, and especially if they've been boosted, they have a much higher level of immunity, which means they can resist more viruses flying in their direction. And the other, of course, variable is going to be how infectious is the infected person in terms of the amount of virus that they're shedding at that point in time. And finally, is it a household setting? Is it a restaurant? Is it a dance club? You know, different places where there could be very different amounts of virus flying through the air. We've always regarded household exposures as being the prime evidence of likelihood of exposure, because in the same household, it turns out no matter how careful you are, there's always some breakthrough infection or transmission that occurs because people in households live in close quarters over periods of time.
So thank you both. And thank you to the entire panel. We've got a lot of questions left, but we're out of time. We very much appreciate the audience participation and the panel's expertise. And for better or worse, we look forward to seeing you at the next webinar. Have a good day, keep masked, get vaccinated, and stay healthy. Thanks a lot for coming.